We are back on Morning Line. It is our final segment this morning, talking about, as you see on the screen, babies born dependent on opioids. Dr. Stephen Patrick's with us from Vanderbilt, works with a lot of these infants. Again, not the prenatal part of it, but after the child is postnatal, born, and how you go through this. But if you'd like to join in the conversation, 737-7587, and we were just talking about what needs to be done in terms of, the decision to be made to send them back or whatever. Again, you treat the mother and the infant, but if you see something like this, you do have to report it to the Department of Children's Services. Sure. And then it is their call, not yours, whether or not it's a safe situation to send the child home with.
That's
correct?
Right. That's right.
Now, and do they question you, or you just give them? It's the same thing if you at the hospital see a child that comes in, sign of physical abuse, right?
Right.
Those kind of reports.
That's right.
Fairly standard, yeah.
Yeah. So we and what we try to do is have policies and do the same thing every time. You find that if you pick and choose when you enforce things, then you just promote bias.
Right.
So so for illicit substances, we report that to DCS. Period.
Okay, and then they can look into it and
we
find
talk to families about that too.
Yeah.
So that families are aware that we do that.
What's usually the reaction on that?
Again, it's just part of that relationship, and it's best actually if you can have those conversations even before the baby's born, so that you can build a trusting relationship. I mean, people understand that that's just what you have to do in your job. I mean, I always think that being upfront, being honest, and having that conversation is always the best.
And I think something with these mothers and the fathers, if they're there after the child's delivered and they see the child, and hopefully they want to make change. I'm just curious, just some of the experiences you've had with the mothers after the child's born, and the mother knows she was doing it, and the mother sees her child maybe going through withdrawal, which is a painful thing. What's the interaction like, and what's the reaction? Is it guilt? Is it fear? Is it anger? Is it I don't care? Or you see a little bit of all of it? Well,
look, I think when I first was exposed to this, I didn't really understand the situation. For many of these moms, they have a long history of trauma. They themselves were abused as children. We learn more and more that we learn about that. I mean, I can think about a baby that I took care of a couple of weeks ago, called to the bedside, close to midnight, the baby going through increasing withdrawal, and it's a young mom standing next to, about 19 years old, who was doing everything right. She was taking buprenorphine for her opioid use disorder, and her infant was starting to have some signs of drug withdrawal, and she was just distraught. She was taking the drug to wean herself off while she was pregnant, or after the fact? While she was pregnant? Well, it maintains during pregnancy.
Okay, so she had been using. She knew she was. So she was taking this drug to wean her off. Got treatment, but the baby still was exposed, right?
Yes, but again, we know that when she gets that treatment, it decreases her baby's risk of preterm birth, and so again, that's really the standard of care for a mom to be in treatment like that. With a medication like buprenorphine.
Okay. And so you walk in and she's standing over the baby.
Yeah, she's distraught. I mean, can you imagine seeing you're doing everything throughout the pregnancy to try to have a healthy pregnancy, and then you see your baby going through withdrawal? Yeah, it's emotionally trying for the mom. The dad was there, the nursing staff, and so part of it is, again, what we want to do is step back before pregnancy. How do we prevent this way before pregnancy occurs? But we need to expand treatment in pregnancy, and there does need to be a level of compassion for these families, because again, so often I see families that are trying to do the right thing, and we oftentimes, and I include myself in this, we respond with judgment, and that's often not.
I know, because you're angry because you see the child that's innocent suffering, but you have to step back and understand this. Now, I would imagine, I hope most of the cases are a reaction like this mother who was very distraught to see the child suffering a bit there. Have there been some where they just don't give a hoot?
Yeah, I mean, look, we have the entire spectrum of patients, right?
I'm guessing. And so meaning the baby's finally here. Great, I can get out of here and start doing my pills again. And then, by the way, does it get into the breast milk?
I would say, first off, again, once people see their baby for the first time, imagine, I remember when I saw my baby for the first time, there is something that shifts in you. People want to make changes, people want to be there with their baby.
Sure.
I think that's the more common reaction that I see. Yeah, there can be transmission in the breast milk. It's generally very small. For women who are in treatment and are not relapsing, breastfeeding is safe. It can promote bonding. It decreases withdrawal severity for the baby too. And so we promote that when, again, there's no relapse. If mom's using buprenorphine or methadone, that's completely safe.
Gotcha. Let's take a call from Kenneth. Kenneth, good morning. Are you there, Ken?
Yeah.
Hey, go ahead, Ken. We got you real quick before we get to the end of the show. What's on your mind?
Well, I had a friend which he was on, coke and opioids, and they put him on methadone. So the methadone, he said, was a whole lot better than all that other stuff. And he couldn't get off the opioid. I mean, the methadone.
Oh, so he ended up getting hooked on the methadone, but aren't they never weaned him off it? Did he still just keep taking it?
Yeah, he said he couldn't. He went to rehab and got out, got right back on it. And he said it was way better than the others.
Oh, meaning he liked the feel he got from methadone. Now, again, methadone and naloxone, these are all drugs too, right? Are they just methadone? Yeah, he ended up addicting to that. Isn't the idea, though, to eventually win him off that as well?
Right. And so, methadone is different in the way that it affects the way it's a full opioid agonist, as we say, whereas buprenorphine works a little bit differently. You may not have some of the same feelings, but again, this is one of those things where you think about someone who's going through and using like heroin, something like that. They see intoxication, withdrawal, intoxication, withdrawal. What methadone or buprenorphine does is it levels things out over time so that you can get things in order. For some people, they require that forever to be able to live a functional life, but many times people will taper off over time and then live their lives. It's a way to sort of take control of what's going on.
And did you say Suboxone is another one that they give? And
yeah, that's right.
If you're taking Suboxone, is that the drug, or is there another one where you take it, and if you take an opioid with it, it could really be bad? I mean, like, I guess they're all opioids. So, but
yeah.
Suboxone is supposed to wean you off something that's more powerful, like hydrocodone or something.
That's right. So that's buprenorphine plus naloxone. That's the combination product. And so that is to maintain people during pregnancy. There's three main drugs. There's methadone, there's buprenorphine or Subutex or Suboxone, and there's naltrexone, which is a long-acting. It basically blocks your ability to have a high afterwards. Okay. Two of those can be used in pregnancy.
And again, it's important because withdrawal can be a very serious health problem as well. What if there's a woman who's been doing the pills? She gets pregnant, and then she does them a bit, and then she goes, wait a second, I'm pregnant. Darn it, that's it. And she goes cold turkey. Okay, and then goes into massive withdrawal, including the child. That could almost be more dangerous than going to the doctor and getting on some of these, right?
Yeah, abruptly stopping opioids in pregnancy can lead to miscarriage. Okay. So that's why it's important to talk to your obstetrician and potentially get it.
So almost not. I mean, the idea is you need to go get help, but if between going cold turkey and still taking it,
talk to your doctor.
Talk to your doctor.
And there are laws in the books here in Tennessee now. Something called the Safe Harbor law too. If you seek treatment before 20 weeks of pregnancy, your baby can't be taken away, and you can't be prosecuted just for the substance use. So go seek care.
I'm glad you mentioned that. You can safely do so without worrying about losing the child. Let's go to Danny. Hi, Danny.
Hey.
Hey, what's on your mind?
I've been a patient on Suboxone for about 8 months now, and I started a program when I used it. And my question to the doctor is, when I started this program, it was hundreds of dollars. Now, it's definitely been a life-changing experience. I absolutely was saved by this, medication and getting off of pain medication. But it was extremely expensive. I mean, hundreds of dollars a month. And my question is, I see a lot of people that really need that kind of help, and a lot of them are poor or in the dumps or low income. And I mean, how do you get those programs down cheaper to where people can afford them? That's my biggest question.
That's a great question, and probably the ones that are most cash-strapped can be these young mothers, maybe, especially if they're alone.
I would say first, thanks for the courage of sharing your story. Thanks for making that call and for the step that you made for recovery. I share that concern that oftentimes there are either for-profit clinics. It can be really expensive to get treatment. It shouldn't be this hard to get treatment in the United States today. We've seen some policies that have changed over the last couple of years. The 21st Century Cures Act had some dollars to expand treatment, but it's not enough. And I think in some states, treatment's harder than other states. And I think treatment should be accessible. And not all treatment centers, as you sort of alluded to, not all treatment centers take Medicaid or even private insurance. And so expanding access to treatment where people can afford it, particularly in rural areas, is important because it's expensive. And I think that's a really important point.
And is the expense with treatment, I don't know if you know off the top of your head, for instance, how much would a bottle of 60 tablets of Suboxone cost me if I wanted to pay cash standard? Do we know what a pill costs of Suboxone?
I don't know the answer to that.
Okay.
I do know that for people that are in methadone or Suboxone treatment programs, it can be hundreds of dollars a week, depending upon the place. You have to go. So methadone, you go to an You go to an opioid treatment program. Suboxone can be prescribed by an outpatient doctor, and again, you have to go there to get it. So that treatment combined together can be hundreds of dollars.
I'm trying to remember, Nashville Cares in town, and they deal with a lot of HIV and such. And I know they give out drugs, but I wasn't sure how. Some people I thought would go there sometimes to get their methadone, or I don't know if it was Suboxone, or and I'm trying to just think, how they can afford to do it, how people can afford to go to these places. You can't. The treatment, though, is not just the drug; it's also the counseling, the interaction with the individuals that are administering that drug, right?
That's right.
And that's where it gets expensive. It needs to be made more affordable. We don't have enough drug treatment beds. You talk to the sheriff who comes on this show every month, and he's going to say, you go over there to the jail. Well, it's not there now, but the one out on Harding, and the vast majority of mental illness and drugs. That's it. That's it.
And it's not just beds. We can do outpatient treatment too, but we need more of it, and it needs to be less expensive. We're starting to see complications from drug use too. From our team, we along with Tennessee Department of Health, published a paper in the last couple months looking at hepatitis C rates among pregnant women, which have doubled nationally. And in Tennessee, it's about 1% of births are now exposed to hepatitis C. 1 in 50 babies in West Virginia are exposed to hepatitis C. Wow. And so this is where treatment is effective at reducing risk of hepatitis C. We know that it works. We know that it reduces risk of death for the gentleman that called, as well as the general population. It should be more accessible.
By the way, hepatitis C, the infants, that stays with you for the rest of your life, right?
Well, there are treatments now. They are not. There's some trials ongoing to look at infants, but there are medicines now that are pretty life-changing that can be a cure.
Can cure it or just subdue? Because hepatitis C will destroy your liver, right?
It will, but there are new, very expensive drugs that can clear hepatitis C. They've not been, to my knowledge, yet approved. They're certainly not approved in pregnancy and for young children either. So,
but that's coming now. Is that right? For Hep C, huh?
Yeah.
Okay, and that it might actually be able to cure it.
Yeah. Absolutely. There are blockbuster, life-changing drugs that are there, but it's hard, but they're very expensive. And it's been a challenge for many, particularly state Medicaid programs, to understand how to pay for it.
As we wrap things up, I mean, you see this every day. You're heading out from here to head back over to Vandy. But, I mean, are you overwhelmed or are you optimistic?
Well, I'm a pediatrician, so I'm optimistic.
Okay, I can tell you are. You're a good, optimistic guy.
Look, I think we need sustained conversation. Look, and it's a national conversation. Tennessee has a lot of thoughtful public health leaders that are in the space. Tennessee Department of Health and TennCare have done some really positive things. We need to continue the national conversation around opioid use. We still don't have. There's no drug czar yet that's been nominated nationally. We just need. This has been a bipartisan issue. We need to continue the conversation about this. How do we decrease the amount of our neighbors, friends, and sisters and brothers that are dying from opioid use? That broad conversation is going to improve population health overall, and it's going to improve outcomes for moms and babies too.
Doctor, thank you for coming on. It's a pleasure.
Pleasure to be here.
Great job. I learned a lot just listening to you. It's fascinating stuff. A lot of the stuff I had an interest in, and hopefully you learned as well. And take this into account. Spread the word, the education of it. We'll do more shows like this. I really appreciate you coming on.
Absolutely.
Take a break. Programming note about tomorrow right after this. Stay with us. Great job.